Good morning. My name is Nizar Jarjour, and I am the division head for allergy, pulmonary, and critical care medicine. I want to welcome you all to our Department of Medicine Grand Rounds. This morning, it's my great pleasure to introduce our Grand Round speaker, Dr. Lynn Schnapp, who became our Department of Medicine chair on March 1st, 2020. I am sure that when she accepted this position, leading us through a pandemic was the farthest away from her mind and from anybody else's mind, for that matter. Uh, as you probably know, the past couple months have been quite unusual for most of us, and it has been so fortunate to have Lynn leading us through these past 2 months. Dr. Schnapp earned her bachelor's degree in biology from MIT, completed her MD and medicine residency at the University of Pennsylvania School of Medicine, and then did pulmonary and critical care fellowship as well as postdoctoral research at UCSF, where she remained on the faculty for several years before moving to the East Coast, Mount Sinai. Then back to the West Coast at the University of Washington in Seattle, where she rose through the rank to become a professor of medicine. From there, she was recruited back to the East Coast, Medical University of South Carolina, where she has served as the pulmonary, critical care, allergy, and sleep medicine division head from 2013 until we were fortunate enough to bring her to Madison in March of this year. Dr. Schnapp is currently the vice president of the American Thoracic Society. This is our largest professional organization for the specialty in the country and the most prominent in the world. She will serve as president of that society in 2021-2022. Her honors include the American Thoracic Society Elizabeth Rich Award for Research Accomplishment, the NIH Mid-Career Mentoring Award, and the University of Washington School of Medicine Award for Mentoring, as well as the Advancement of Women Faculty Award at MUSC. On the research front, Dr. Schnapp has had a long-standing stellar career with NIH-funded program on lung injury and repair, focusing on mechanism of scar formation during acute lung injury and idiopathic pulmonary fibrosis. Her laboratory utilizes a wide array of technology, including mouse models, computational and pathway-focused network analysis, proteomic, and transcriptomic. Her team's current work is focused on understanding the role of pericytes in the immune as well as fibrotic responses in the lung. In addition to being very active in research and leadership at the highest level, Dr. Schnapp has maintained a clinical practice as an ICU physician, and soon we will be looking forward to her attending on our critical care services. She and I couldn't wait for that to happen. It's my great pleasure to welcome you, Dr. Schnapp, to the Department of Medicine and invite you to speak to us today on ARDS, Days of the Future Past. Dr. Schnapp.
Thank you. Thank you so much for the kind introduction. And I am delighted actually to be talking about medicine and clinical issues today. So the title of my talk is ARDS, Days of Future Past. And I've gotten a few emails asking me whether this was in reference to the Moody Blues album. And actually, this is in reference to the X-Men, Days of Future Past, which is my own, it shows my own cultural leanings. And I'm going to be talking about ARDS and with some references in the COVID era. So I've gotten, as my disclosures, I've received research grants from the NIH, from Horizon Pharmaceuticals. None of them are relevant to today's discussions. And I'm going to be focusing really on clinical work that's been and clinical trials research that has been done by others. So today's objective is to review the history and definition of ARDS, to understand the seminal studies for management of ARDS, and finally to discuss some of the management strategies of COVID-associated ARDS. So I usually get my medical information from the New York Times. And this was an article a number of years ago by Lawrence Altman, one of the science writers for the Times, talking about this deadly lung ailment that had battlefield origins. And he was talking about ARDS. So what is his reference? So if we go back to World War I, the Great War, this was the first time there was use of chemical agents on the battlefield. And of interest, so the first chemical agent that was used was chlorine gas. The problem with chlorine gas is it's highly irritating, and so when it was used, soldiers would cough violently, and that would really limit the exposure to the gas and limit the injury, and also inform them that there was that chemical gas was being deployed. So they actually switched to phosgene, which is much less irritating and allowed a greater injury. And it was fairly devastating to the battlefield. And this is just a description by a soldier, Wilfred Owens, of the impact of the phosgene attack on the respiratory status. And if in some smothering dreams you too can pace behind the wagon that we flung him in and watch the wide eyes writhing in his hanging face, like a devil sick of sin, if you could hear at every jolt the blood come gargling from the froth-corrupted lungs, obscene as cancer, bitter as the cud. And so flash forward to the Vietnam War, and there was a description of Da Nang lung. So Da Nang was where the US Marines first landed in Vietnam. And by this time, the trauma resuscitation had become much more advanced. So soldiers who may not have survived their initial injuries in prior wars were now surviving due to rapid triage and transfer to field hospitals and fluid resuscitation. And what they started describing is this respiratory distress syndrome that came on 1 to 3 days after their initial injury, often was unrelated to where their initial site of injury was. And it resembled that shock lung so much that the military believed that the Viet Cong were using chemical agents in warfare during the Vietnam War. Now, around the same time, David Ashbaugh, who is a surgeon, and Tom Petty, who is a pulmonologist, came together at University of Colorado and formed the first multidisciplinary ICU together. And this is one of the seminal papers in pulmonary medicine, their initial description of acute respiratory distress syndrome in adults. And what they had observed, this is actually a case series of 12 patients. Most of them, as you can see, had trauma, were on the young side, and they described a syndrome where patients presented with severe dyspnea, tachypnea, cyanosis that's refractory to oxygen therapy, loss of lung compliance, and diffuse alveolar infiltrates on chest x-ray. Their mortality rate was 60%, and this is the first application of PEEP for a hypoxemia. They also noted, and this will come up a little bit later, the potential contribution of fluid overload in the presentation. And there's some really wonderful articles, if you're interested in medical history, of them talking about this whole this episode. And I want to emphasize, particularly for trainees, what they talk about this article. They were so proud of it, and they submitted it to 3 journals where it got promptly rejected every time until it finally got accepted by the Lancet. And it is now probably one of the most cited articles in critical care in ARDS. Everybody starts every grant, every manuscript. ARDS, first described by Ashbaugh and Petty in 1967. And as I mentioned, this was the first description of PEEP in ARDS. And Tom Petty, no relation to Tom Petty and the Heartbreakers, I might add, talks about that episode. Dave Ashbaugh found an old 1954 model of the Engstrom anesthesia ventilator unit in storage. We both read the instructions and still wondered what the expiratory retard control on the exhalation manifold meant. He wrote, I helped Mike, who at the time was a pulmonary fellow, use the angstrom for the first time in his training. What does this knob do? Mike asked. And I said, I think it's probably useful since Dave used it to improve oxygenation in a crushed chest patient a couple of months ago. I then dialed in positive end expiratory pressure of 10 centimeters, and it was dramatic to see a blue patient lying in Trendelenburg gradually flush to a healthy pink color, blood pressure improve. We stood there amazed. We need another gas to see what's going on. This was the start of PEEP, turning knobs they didn't know what to do with. So we flash forward almost 50 years to the current definition of ARDS based on a, it's called the Berlin definition. That's where they met to come up with these criteria. And what's really remarkable is the criteria really have not changed in 50 years. They've been tweaked and modified, but it's basically almost exactly what Petty and Ashbaugh described in 1967. So the diagnosis of ARDS is based solely on clinical and radiographic criteria. It needs to be acute onset, bilateral opacities on imaging, and that imaging now can be chest X-ray or CT, edema that is not fully explained by cardiac failure or fluid overload, and hypoxemia, defined as PaO2 to FiO2 ratio of less than 300 millimeters of mercury with a on PEEP of 5 or more. And so what do we see in ARDS? What is ARDS? Well, you think about it as really an inflammatory state that affects both lungs. And what we classically see is activation and injury of both the endothelial and the epithelial compartments. And that's manifested with increased permeability. We see robust inflammatory cell recruitment. We find hyaline membranes, which are this proteinaceous material in the alveoli. And particularly with later ARDS, we see fibrosis. And the classic histological description is diffuse alveolar damage. Now, in addition to inflammation affecting both lungs, we also know that there's actually whole body inflammation in association with ARDS with elevated cytokines throughout. And we'll talk a little bit more about that as well. What do we see on histology? Well, on the left panel here is the normal lung, a nice, lacy, very pretty, thin alveolar structure, plenty of surface area for gas exchange. And in early ARDS or the exudative phase, you can appreciate the inflammatory infiltrate all the blood cells, this proteinaceous material, the hyaline membranes in the alveoli, and you can imagine why this patient can't breathe, why they're hypoxemic. In the fibroproliferative stage of ARDS, usually defined as greater than 14 days, you actually start seeing fibrosis. You can see collagen deposition, you have evidence of fibroblast activation, and actually this is the stage that I'm very interested in, because in ARDS, what's fascinating is that if you survive your initial injury and you survive your ARDS, in the vast majority of cases, this fibroproliferation resolves. And why does fibroproliferation resolve in ARDS and yet persist in other entities? Classic chest X-ray with ARDS, normal chest X-ray, good aeration of the lungs. ARDS, bilateral diffuse infiltrates in an intubated patient. Now again, ARDS is not a disease, it is a syndrome, and it's caused by a variety of etiologies. You can think about it direct insults to the lung and indirect insults into the lung. So the most common direct insults to the lung include pneumonia and aspiration, but really any injury to the lung can cause ARDS, inhalation, pulmonary contusion that we see in trauma, fat emboli, near drowning, reperfusion injury. And then indirect is also quite common, particularly sepsis and severe trauma. But again, anything with where you're really sick can cause ARDS. Pancreatitis, transfusion-related lung injury, burns, head injury, cardiopulmonary bypass, etc. So when Ashbaugh and Petty described ARDS, the mortality rate was 60%. And fortunately, the mortality has improved over time. This was from 2016. This is patients with severe, moderate, and mild ARDS. And we currently have a mortality anywhere from 40 to 25 to 40% mortality with ARDS. So still a significant mortality, but there has been major changes, major improvements in the mortality. I will say it was stuck here for a long time. And the question is, how did we get from this to here? So I like showing this chest x-ray. This is a chest x-ray from a patient I took care of when I was a fellow. And this is the classic chest x-ray of patients with ARDS when I was in training. And hopefully you can appreciate multiple chest tubes throughout on bilateral chest tubes. There's still a persistent pneumothorax here. There's air in the mediastinum. There's subcutaneous air throughout. And this is a mess. And this, as a matter of fact, this is one of my earlier articles. I'm talking about barotrauma in ARDS patients. Well, starting in the 70s, there was increasing appreciation of the potential downside of how we were treating our patients. And in particular, Jerry Mead, who's probably one of the giants in pulmonary physiology, was one of the leaders in this field. And this is a really fascinating article because it's all models. It's all equations and it all models. And they're talking about stress distribution in the lung. And I thought, it's really very insightful because what they state is mechanical ventilators, by applying high transpulmonary pressure to the non-uniformly expanded lungs of some patients who would otherwise die of respiratory insufficiency, may cause a hemorrhage in hyaline membranes found in such patients' lungs at death. So this was one of the earliest hints that the method that we're using to save our patients may actually be causing damage. Several years later, this is another classic article by Webb and Tierney, looking, because they had the clinical observation that some patients with ARDS required very high inspiratory pressure to maintain a normal tidal volume. And I should emphasize, what we were doing is trying to ensure that patients received the same tidal volume that we normally breathe going about our business, usually 10 to 12 cc's, or sometimes even 10 to 15 cc's per kilo. And they asked, were there negative effects of high pressure other than barotrauma? And this was one of the first demonstrations that lung injury may be induced by mechanical ventilation itself. And this is lungs. These are rat lungs, and these from rats that were ventilated with lower pressure, high pressure with PEEP, and high pressure without PEEP. And what they've demonstrated is that the injury was caused less by the peak pressure than the difference between the peak and plateau. And this, you can see how red or dark this lung is. This is a hemorrhagic edematous lung. And it's this and a number of other studies that were translated into low tidal volume lung protective ventilation. Now, Art Slutsky's group was also one of the first to actually show the biological consequences of ventilator strategies and using an isolated rat lung model. And they showed that here that the last bar is high volume ventilation, and they measured cytokine expression and demonstrated for the first time that there was an increase in cytokine expression with high volume ventilation compared to controls. They then followed that up looking at patients, and this was one of the earliest randomized controlled trials of low tidal volume ventilation, and they demonstrated that patients who received low tidal volume ventilation had decreased in inflammatory cell recruitment to the lungs in the BAL. They had decrease in cytokine expression in the BAL, and I believe systemically. Just go back. And it was because of this data, along with a number of other studies, both in vivo, ex vivo, that led to really one of the most seminal studies in ARDS, which is this article in New England Journal, Ventilation with Lower Tidal Volumes as Compared with Traditional Tidal Volumes for Acute Lung Injury and ARDS. This is a multi-center study that was funded by the NIH as part of the ARDS network. And this was, if you want to read one study in ARDS, this is the one to read. It's a seminal study that demonstrates the first demonstration of a mortality benefit of low tidal volume plateau pressure limited strategy. This shows the improvement in mortality, which is actually really hard to show in patients receiving lower tidal volumes. Their lower tidal volumes was 6 to 8 cc's per kilo, compared to their traditional tidal volumes was 10 to 12 cc's per kilo. They were also able to demonstrate that ventilator-induced lung injury may actually contribute to the subsequent extrapulmonary organ failure, as they showed that, again, in low tidal volume, patients receiving low tidal volumes, they were more likely to be free of organ failure for more days than patients receiving traditional tidal volumes. And this paper, and there have been a number of subsequent papers confirming these findings, have changed the standard of care for ARDS patients, and it's widely credited for the improved ARDS outcomes over the subsequent decades. Now, one of the issues I do want to bring up is, how good are we at using lung protective ventilation? The problem is, for the one therapy that we know really works, we don't use it very much. This is one article from Weiss looking at a variety, just going back to a number of other articles and trying to tease out what percentage of patients what percentage of patients who met the definition of ARDS received low tidal volume ventilation. All of these studies, all of these cohorts were after the ARDSnet study was published, and you can see it's all over the place. This is another large study, the Lung Safe study, which looked at the epidemiology, patterns of care, and mortality for patients with ARDS in ICUs in 50 different countries. And this is the distribution of tidal volumes used to ventilate patients, whether they had mild, moderate, or severe ARDS. And the first thing you can note is that there is no difference depending whether you had mild or moderate or severe ARDS. The treatment was the same. And about in their cohort, 65% of patients who met definitions of ARDS received what we consider lung protective ventilation. And if you look at the ARDS, the original lung protective ventilation study, they actually defined low tidal volumes at 6 cc's. So what this means is 35% of patients are not receiving appropriate medical care. Now, another paradigm is how we manage fluids in ARDS. Again, this is an early study looking at a direct injury model. They instilled oleic acid down into the trachea and wanted to see if you modulated either the hydrostatic or oncotic pressure, did that impact the degree of lung injury? And what they found was that there was no impact of changing the oncotic pressures via albumin. Instead, they showed that if you bled the dogs or added nitroprusside, that the lung injury was lessened, and they attributed this to decreases in hydrostatic pressure. And again, this study, along with a number of others, led to another large study, which looked at the comparison of two fluid management strategies in acute lung injury. And this one compared fluid conservative to fluid liberal management. The conservative management aimed for a CVP less than 4 millimeters of mercury and a pulmonary artery occlusion pressure, which is a pulmonary artery wedge pressure of less than 8. And then the liberal arm was a CVP of 10 to 14 millimeters of mercury and a wedge of 14 to 18 millimeters of mercury. And what they found was that with a conservative approach, there was reduced duration of ventilatory support. So the number of ventilator-free days was higher, but there was no mortality benefit. But it's this and a number of other studies that have led us to the theory that dry lungs are happy lungs. Now, I originally gave this talk about a year ago, and at the time, one of the big questions was the use of early neuromuscular blockage in ARDS. And this is, there is a paper published in the New England Journal in 2010, a multi-center randomized trial where they took patients within 48 hours of presenting with moderate to severe ARDS. All those patients were treated with lung protective ventilation, and they randomized them to either 48 hours of continuous neuromuscular blockade using cisatracurium versus no neuromuscular blockade, and both groups received heavy sedation. And in this study, they showed a significant mortality benefit. Now, this was a highly controversial study at the time. It went against many other studies suggesting that decreasing sedation would led to the ability to liberate from the ventilator earlier, that sedation was associated with delirium, that neuromuscular blockade was associated with myopathy of critical illness. So people were really uncomfortable with the study, and in particular, how their control group, which was the heavy sedation, was criticized significantly. So because of that, in the next iteration of ARDSNet, which is the PEDAL network, which is prevention and early treatment of acute lung injury, they set up the reevaluation of systemic early neuromuscular blockade, or the ROSE study, to address this question of could they replicate these findings. And I will say I'm a little slow because it took me a while to figure out that all of the studies designed by the PEDAL network had acronyms that were a flower. I was like, oh, okay, I get it now. So this was a multi-center randomized study where they enrolled over 1,000 patients within 48 hours of moderate to severe ARDS. All the patients were on lung protective ventilation. And in this time, their comparison group was cisatracurium for 48 hours compared to light sedation and usual care. And the findings, which were published a year ago, basically showed no difference in any of the outcomes. And they also showed increased complications in those who received early neuromuscular blockade. And so it is unlikely that early neuromuscular blockade itself causes changes in mortality in patients with ARDS. And I will tell you that it made me feel a lot better, because I found that initial study very, it just did not jive with my understanding of ARDS and all of the prior studies. So I haven't gone over all of the studies, but there have been a number of clinical trials of supportive care interventions. The ones that are bolded are the ones that have been shown to be beneficial. So lung protective ventilation has been shown and repeatedly to show a decrease in mortality. Neuromuscular blockade, while the initial RCT showed a decrease in mortality, the subsequent study did not show a change in mortality. I haven't gone over this data, but there's actually pretty nice data demonstrating that prone positioning also can lead to a decrease in mortality. And we'll talk a little bit about that in the COVID era. There was a large study looking at high PEEP versus a high PEEP low FiO2 versus a high FiO2 low PEEP strategy, and there was no difference in mortality. Using high frequency ventilation, not only was there no change in mortality, one study showed an increase in mortality. And then the conservative fluid management study did show an increase in ventilator-free days. So those are all what I consider sort of supportive studies of patients with ARDS. But in parallel to those studies, there's been increasing investigation on the biology of ARDS. And this study, was one of the earliest manuscripts to show changes in pathways that may be involved in ARDS. And this demonstrated, looking at 61 patients at risk for ARDS, patients with severe sepsis, trauma, burns, etc. Half of them went on to develop ARDS. And they found that elevated levels of complement in plasma of C5a was associated with the development of ARDS. So this was, again, one of the first studies to try to get a sense of the biology. And I'm not going to go into all of the studies. There's been a lot of work both in vitro, in animal models, looking at patient samples, ex vivo lung perfusion studies. But we've really gotten much better understanding of the role of impaired fluid and ion clearance in ARDS, the role of the disrupted and injured endothelium, the role of epithelial cell injury and apoptosis of the epithelium, the role of inflammatory cytokines, as well as reactive oxygen species, etc. And there's been a lot of work as well on the repair process. A lot of really nice studies investigating mechanisms of ARDS. The problem has been none of those studies have actually translated to a significant outcome in patients with ARDS. This is a summary of a number of studies. Steroids have been tried multiple times, and they're still being tried. I'll report one study. Nitric oxide, no change. Surfactant, calfactant, another variation of surfactant, no change. Beta agonist, statins because of the anti-inflammatory role, antioxidants, fish oil, supplementation, activated protein C, GM-CSF, factor 7 actually showed an increase in mortality, activated factor 7. And so all of these studies have had strong preclinical plausibility and strong preclinical data. So in contrast to supportive therapies, pharmacological interventions have yet to improve clinical outcomes in ARDS. Now, as I mentioned, I gave this talk about a year ago, actually almost to the day. And at the time, this was the list of active studies in ARDS that were enrolling patients. And since that time, I went back and checked what happened to all these studies. So aspirin for ARDS, study was terminated, never reported. Vitamin D in improving outcomes, Violet, so a PEDAL study, no change. The Rose study, which is the neuromuscular blockade, no change. Citrus, another PEDAL study, vitamin C infusion for treatment of sepsis-induced acute lung injury, no change. And they were looking at SOFA score, which did not change, and a series of biomarkers. And I believe of their biomarkers, 42 of the 48 biomarkers did not show any impact of the vitamin C infusion. Ganciclovir, ECMO, although I'm happy to answer questions about that. This study was terminated early for futility, despite some trends towards improved mortality. I will say of the remaining studies, oh, I forgot about this one. Also, no change this was another negative study. So the START study, the mesenchymal stem cells for ARDS, this was a phase 2A study for safety, and that was a successful study. So now this study is in phase 2B, it's recruiting. There is this study, efficacy of dexamethasone to treat ARDS, was just published and completed. They did not, they had to stop early because of they weren't able to enroll sufficient patients, but they did meet their primary outcome of increased ventilator-free days. And so we're going to be in the discussion yet again of what is the role of steroids in ARDS. It's a complicated story. And the remaining studies are still open and have not been reported out yet. So I just want to switch for a few minutes to talk about some critical care management of COVID-19 patients. And what I'm not going to be talking about are really any of the antivirals in this patient population. And I just wanted to focus on a few areas of our patients in the ICU with COVID. So one of the things that has been a topic of discussion here and throughout the country is the reports of microvascular dysfunction and thrombosis in COVID patients. And there's widespread anecdotal reports in small case series of increased hypercoagulability, whether it is reports of DVTs or PEs, or frequent clotting off of lines, of hemodialysis filters clotting off. There have been limited autopsy studies, but there's demonstration of microthrombi seen on autopsy. And there's been strong correlation between really high D-dimer levels and mortality. There's been noted that the hypoxemia often seen seems to be out of proportion to compliance. And one possibility is that this may be due to microthrombi and with worsened VQ mismatch. And probably the study that a lot of people reference is the study that came out of China, recently published. And so this was a retrospective analysis of about 450 patients with severe COVID. And they went back and looked at patients who had received heparin for 7 days or longer, or those who had not. And the first thing to note is when they just looked at straight mortality, there was no difference in the 28-day mortality in either group. So they then did a subgroup analysis. Remember, so this is a subgroup analysis on a retrospective study. And so in those patients who had the 6 score, which I actually had to look up, the sepsis-induced coagulopathy score, it's a relatively new scoring system. So in those patients who had a high 6 score, the patients who received heparin seemed to have a mortality benefit compared to the other group. Similarly, in patients who had had high D dimers that were 6 times the upper limit of normal, they also had a higher survival rate compared to the other group. But I think you have to be very cautious in interpreting the study. Again, retrospective, where their primary endpoint was unchanged, and they did a subgroup analysis. The other thing, when you look closely at the study, so their treatment group, who received heparin, I just think it's really important to look at the doses. So they're talking, these patients received either enoxaparin at 40 to 60 milligrams per day, or unfractionated heparin, 10,000 to 15,000 units per day. That is what we use for our prophylactic dosing of our patients. So I'm not sure that this is a study that tells us that we should be anticoagulating our patients, but my take-home message is our patients with COVID, just like our other patients in the ICU, should be treated with chemoprophylaxis for DVT in the ICU. The other thing I wanted to emphasize, this is kind of my days of future past, the concept of coagulation and fibrinolysis in ARDS is one that has been around for many years. This is a really nice review from Lorraine Ware's group, discussing all of the data suggesting impaired coagulation and fibrinolysis in ARDS. And this is actually part of a table from that paper. I couldn't fit the whole table in, but shows all of the different therapies designed to target the coagulation or fibrinolysis pathways in sepsis and ARDS. And as you are aware, none of these are currently being used because none of them were effective in repeated studies. So again, anticoagulation and therapies aimed at fibrinolysis have failed to significantly improve sepsis and ARDS outcomes. But these features of being hypercoagulable and the retrospective analysis are provocative. And it really calls for the need to be examined in clinical trials. I think many of us are really cautious about jumping to conclusions based on what we know has been demonstrated in the past. So I fully support the need to examine these questions in clinical trials. And there are a number of clinical trials that are currently being done in the COVID patients. Now, the other concept that has been gotten a lot of hype is cytokine storm, and a number of case series describing this hyperinflammatory syndrome with wildly elevated interleukin-6 and ferritin levels and LDH, and almost like an HLH or a macrophage activation type syndrome. Now, hopefully you've realized that cytokine storm and this cytokine surge is seen in ARDS and is part of the initial description. Whether the cytokine storm in COVID is more exaggerated than in other cases, I think it remains to be seen right now. And then steroids is always a question. This was, again, from ARDS, this was Lazarus study that did not show any difference in patients receiving methylprednisolone. And this is a summary of a variety of different studies looking at the role of steroids in ARDS. And although it doesn't include the latest study, it suggests that in this forest plot that steroids, that the meta-analysis favors control, does not favor the use of steroids. And some studies show that actually steroids are worse. There's been, I actually don't have this data, but looking at influenza, there is data suggesting that the use of steroids in influenza have worse outcomes, that there's delayed in viral clearing and continued inflammation. And there is one case series out of China, at least this was as of last week. There may be more. It's been, it's hard to keep up with everything that's coming out. So it's really hard to know. And as we all are aware, there's a number of cytokine targeted therapies, ongoing clinical trials for IL-6 receptor antagonists. There's non-randomized case series with tocilizumab. There's a number of other studies currently being done. But I do think it's very, it's important to look back on what we've done in sepsis. And every single study where we have tried to target a single cytokine in sepsis have all failed. So again, I support looking at this in clinical trials. I remain skeptical whether cytokine targeted therapies are going to be effective in COVID in sepsis or ARDS. I do want to take just a second to talk about inhaled vasodilators. These do improve oxygenation. None of them have been shown to improve outcomes. It is something that we use as a last resort in patients with refractory hypoxemia that we have nowhere else to go. The two common inhaled vasodilators are epoprostenol as well as inhaled NO. In general, people favor using epoprostenol because there is data in inhaled NO that there may be increased incidence of acute kidney injury. However, it's also a little bit complicated whether there's some of the fluid conservative therapies may have complicated this. I would say in the case of COVID, one of the things to realize about epoprostenol is that it is needs to be nebulized. The diluent is very sticky, and so that means there's lots of filter changes and you have to replace the nebulizer. So there is a much higher risk of aerosolization when using this. So in general, most of us are recommending the use of inhaled nitric oxide if needed. There is some in vitro data suggesting it may have antiviral properties in SARS, who knows? But from a practical standpoint, it's bled directly into the ventilator circuit. You have less interruptions of the circuit, less chances for aerosolization and contamination. However, with both of these, there are reports of considerable rebound hypoxemia when you try to titrate it down. So in summary, for COVID-associated ARDS, lung protective ventilation remains the cornerstone of ARDS management, with COVID, without COVID. There is a fair amount of experience now suggesting that prone positioning, which we do know is effective in ARDS, is very effective in COVID patients. There is not clear what PEEP, whether it should be on the higher PEEP or lower PEEP. I think that needs to be individualized. In volume status, I tend to be judicious with fluids. There are a number of reports of kidney injury in patients with ARDS, and whether my recommendation would be keeping a patient even, and maybe a little bit on the negative side. But really, the management of this potential hypercoagulable state and inflammation is controversial in our COVID patients, and it really needs further evaluation in clinical trials. In general, what are the challenges for ARDS? I think, one of the challenges for us is we study a syndrome. It's not a disease. We don't have molecular classification. We don't have great biomarkers. And there's increasing evidence that there is clinical and biological heterogeneity within our ARDS patients that really may influence treatment response. So I'm not talking about it today, but there is a fair amount of effort going into identify markers of predisposition for ARDS. Are there SNPs that increase your risk for ARDS? Are there polymorphisms that increase your risk of doing poorly with ARDS? How do we bring personalized precision medicine to ARDS? We have yet to be able to translate our knowledge about the biology into effective therapies. It is likely to require subgroup targeted therapies, again, more precision medicine, so we can have some enrichment in our clinical trials. I think really importantly, we need to improve the implementation of the interventions we know to be beneficial, whether it's lung protective ventilation, whether it's the use of prone positioning, etc. I think for me, this is low-hanging fruit. And then we need to translate our benefits into long-term patient-centered outcomes. And finally, I want to direct you. There have been a couple of really thoughtful editorials and perspectives. The first one was published in JAMA. It talked about treating COVID-19 off-label drug use, compassionate use, and randomized clinical trials during pandemics, and used the Ebola outbreak as a model, and asked why were new therapies not discovered for Ebola. One reason is because virtually all the studies were single group interventions without concurrent controls, which led to no definitive conclusion related to efficacy or safety. He also commented, a common interpretation of off-label use and a compassionate use of drugs is that if the patient died, they died from the disease, but if the patient survived, they survived because of the given drug. It's just simply not true. In the New England Journal last week, drug evaluation during the COVID-19 pandemic. And they concluded for the COVID-19 pandemic and other pressing medical challenges, the health of individual patients and the public at large will best be served by remaining true to our time-tested approach to clinical trial evidence and drug evaluation, rather than cutting corners and resorting to appealing yet risky quick fixes. And we are trying to ensure that every patient that comes into the hospital with COVID has the opportunity to enroll in a clinical trial. We currently have convalescent plasma trial up and running, and another trial is coming on board Monday, I believe, and we're continuing to evaluate others from there. So with that, I'm going to end and say thank you. I want to give a shout out to Andy Goodwin at MUSC, Carolyn Calfee at UCSF, Ellie Golensdanen. I'm not sure if I pronounced your name right, Ellie, so I'm sorry. Who've all been very generous and shared some of their slide decks with me. And then most importantly, our patients and our families, because this is why we do what we do and trying to improve outcomes for them. So I think that's what I have. And I am going to stop sharing. And I am happy to take questions.
Thank you very, very much, Dr. Schnapp, for our most exciting, wonderful presentation, certainly from past to the future. Wonderful. Questions, please.
Okay. So
you can probably read them in the Q&A.
Okay, I'm going to try to read them. ACE inhibition prevents degradation of bradykinin and is thought that this effect is the cause of ACE inhibitor-induced cough. Bradykinin increase capillary leak and could contribute to the diffuse infiltrates of ARDS. Has ACE inhibitors been found or suspected as an independent risk factor for ARDS? People, and so probably Jim might know this better. It has not been found to, well, it has not been looked at as rigorously as one would like in terms of a risk factor for ARDS. There is studies looking at the role of angiotensin in the treatment for ARDS, but as of yet, it has not been validated. See, and then I'm trying to look in. Okay, given that so much has failed for treating ARDS, what about upstream interventions to prevent cytokine release? We use early antibiotics for bacterial infection. So, I think that's a great question. And the biggest problem is we don't have markers of early ARDS. And what we now think is that when patients present and we define them as ARDS, the cat's out of the bag. So the PEDAL network is specifically trying to identify early interventions to do exactly that. The challenge is capturing those patients in a timely manner. And so all of those PEDAL studies actually involve emergency room and ICU. So getting patients the minute they walk in the door and doing an intervention. So that is exactly where the field is going, is to try to keep the cat in the bag before it comes out. Is obesity a factor in prone improvement? It has not been, to my knowledge, well studied. If you look at many of the studies, if you look at the ARDSnet study, actually, they excluded patients with morbid obesity. So, we extrapolate to those patients, but we haven't studied them specifically. But we do prone obese patients if we can. What would you, which do you think would be most promising and worth our investment? I'm assuming this is in terms of which clinical trials should we be investing in. I think this is just me, not my own personal opinion. I think the bang is going to be in convalescent plasma and in specific antivirals. I am not as excited about the anti-inflammatories in COVID-19. And so that's where I would put my money on. In COVID-19, is there a component of direct viral cytotoxicity in addition to the cytokine storm and inflammatory damage of ARDS? So that's an excellent question. One of the things we were just talking about is the limitation of the number of autopsy samples that we have. So we really don't have a great idea of what the biology is, particularly for those patients who, what the histology is, particularly for those patients who improve. We don't do lung biopsies on any of these patients. My suspicion is that there probably is indeed direct viral cytotoxicity in the lung in addition to the cytokine storm. It's what we see with influenza, it's what we see with other severe infections. So I suspect, yes, there is direct viral cytotoxicity, and then yes, I think there is a secondary cytokine storm. As a syndrome, have there been efforts to phenotype ARDS? Yes. So there are a number of attempts at trying to phenotype ARDS and to target certain populations. And there has been a lot of effort to try to find biomarkers exactly to identify potential responders. So that is a lot of effort across the country, across the world, has been targeted for that. Is leukopenia a general finding in ARDS or is only seen in COVID-19? Leukopenia is not a typical finding in ARDS per se. We often see it, however, in patients with severe sepsis. So it is not characteristic of ARDS, but more associated with sepsis and in COVID-19. How can our respiratory therapy and nursing teams help us with implementation of best practices? In other settings with other healthcare team members often do better with guidelines. Yes, we don't do very well as physicians. One of the challenges when you look at what are the barriers for implementing lung protective ventilation, one of the major barriers is failure to recognize that patients have ARDS. So there's work on trying to build into the electronic medical records how to flag patients that meet criteria for ARDS. It's difficult because it's not simply hypoxemia. There's the acute nature. There's the infiltrates. I think building templates for lung protective ventilation. There is increasing evidence that lung protective ventilation is good for all patients who are intubated, not only patients with ARDS. So I think engaging our respiratory therapists in particular is important. One of the things that, and I don't know if we do it here, Nizar maybe can let me know. So lung protective ventilation, the 6 cc's per kilo is based on ideal body weight, not actual body weight. In order to calculate ideal body weight, you need to know what the height of the patient is. So every patient that comes into an ICU needs to be measured, and that needs to be input into the chart in order for you to figure out what the right tidal volume is. That's not always done at many places. So, an early intervention is make sure the height of patients is measured during their initial evaluation. So, who is Engström? The Swedish. So I don't know. I have to go back and look at who Engström was. It's not but I need to figure that out. That's a great question, and I love history. So Jim Stein, observational studies go both ways on ACE inhibitors. Some show they get better, some shows they don't. Any thoughts on awake proning on milder cases as a means of preventing progression in COVID-19 ARDS? So this is a fascinating question. And so when we talk about prone positioning, we generally are talking about patients who are intubated and flip them on the stomach. There's increasing reports of trying to prone non-intubated patients. And there's some really cool use of like pregnancy pillows to help patients be comfortable. My thought is, I think it's worth trying. If you can get a patient comfortable to do it, I think it's very reasonable. I didn't go into some of the biology behind it, but it's when you're prone, you have better ventilation perfusion matching. You have more of your lung that is able to be oxygenated and ventilated, just because of what the anatomy of the lung is in the supine versus the prone positioning. So I think it's worth it. I would do it if I could. Okay, so I think this is the end of our hour. I really appreciate all of your attention. I am happy to, if you want to email other questions, I'm always happy to take questions about ARDS and the ICU anytime. So thank you all. And
thank you very much, Dr. Schnapp, and thank you all for joining us this morning. Okay. Good day.
Bye-bye.